all of us know him. We have learned from his teachings all the way throughout our trainings, especially on skull base, on the cavernous sinus. Professor Dolenc is one of the pioneers in the field of skull base and the cerebrovascular and cavernous sinus surgery. He introduced microsurgical techniques and surgeries of all kinds to us. He began his specialization in Yugoslavia. He started his career operating on peripheral nerves, the first one being in 1969. He initially used microsurgical techniques only in reconstructive interventions in damaged peripheral nerves, and then organized 4 microsurgery workshops on this topic in the 1980s. In the 1974, he introduced the neurosurgical techniques of intracranial aneurysms. He was among the first neurosurgeons that operated on a ruptured aneurysm. Now, I asked him a few minutes ago, he told me he was the third one to operate on ruptured aneurysms. In the 1990s, he started neuroanatomy research in the paracellular space and started operating on vascular irregularities and tumors in the cavernous sinus. He organized multiple symposiums, congresses on the topic. He published over 200 scientific articles and more than 100 comments for different articles, and he wrote one of the landmark books on the cavernous sinus and skull base. One was the microsurgical anatomy and surgery of the central skull base, which is considered one of the fundamental for neurosurgeons in every field. I don't want to waste Professor Dolenc's time with more introductions. He really doesn't need it. So please, Professor, I will stop sharing my screen and your time to share. Thank you.
Thank you very much. Just a second. Okay. Okay, this is my really great pleasure to be.
Professor, one comment. We are seeing your working station on PowerPoint, and now we will see your presentation probably. Let's see. Okay. Yeah, that's fine. Thank you very much. Thanks.
Thanks a lot. So this is my second time to be present in Seattle. The first one was many years ago when I was put on the podium with endovascular people, and they were waiting that we will fight, but we did not. And today I would like to tell you a few fragments of what happened in neurovascular surgery during the 200 years. A sudden hemorrhage with catastrophic consequences happened in 1810. That was the first week of May when the Gustav Adolf Ford was forced to abdicate from his position. This was after the Swedish-Russian War. And then the new royal dynasty was founded, the Danish Count of Augustenberg. He was renamed from Christian to the Charles. And the Charles organized a meeting of the government north of Lund on May 31st. But after the lunch, they went hunting and he fell down from his horse and died. As it is usually that somebody has to be guilty. And they said that Axel von Fersen poisoned him. 3 days later, When the funerals took place in Stockholm, this poor guy, Count Axel von Fersen, was stoned and beaten to death. 3 days later, the report came that he was not poisoned, but that he had a bleeding. And then a new person was put to the place, and that was brother-in-law of Napoleon's brother, Marshal Jean-Baptiste Bernadotte. And the present King of Sweden, Carl Gustaf XVI, is the 7th descendant in a direct line of this dynasty, and thus, with all probability, owes his royal patronage to the rupture of an intracranial aneurysm over 210 years ago. The classical description of SAH was in 1813. Norwegian physician Edvard Pohl had a patient, a teenage girl who had the third nerve palsy, and he said this is aneurysm of the carotid artery. And he also suggested that it would be she could be operated. However, she died because she was not operated. He was aware of Thomas Willis' anatomy and of the circle of Willis, which was published already many years ago. And Edward Pohl suggested that the ligation of the carotid artery might have prevented the second bleeding. And then later on, introduction of cerebral arteriography in 1927 by Egas Moniz and Almeida Lima in Portugal was introduced. In July 1932, these pioneers visualized the very first intracranial aneurysm by arterial contrast injection. Norman Dodd in 1932 was the first in UK who demonstrated aneurysm by angiography. And on 27th of October 1932, Dodd performed his first ligation of the carotid on a young patient. Norman Dodd published later on the statistic of 39 patients with subretinal hemorrhage. Now the mortality was by intracranial surgery at that time 67%, but at the ligation of the carotid only in 25. Norman Dodd never denied fear, and this is important for young people to remember, that the courage implies an appreciation of risk. In fact, it implies fear under control. And he who, and she also, who knows no fear is not courageous, but reckless. Walter Dandy, well-known neurosurgeon in USA, first carotid ligation in the United States on a patient who had third nerve palsy, and the patient survived, did not survive. Then Dandy published his experiences of the treatment of ICA aneurysm within the cavernous sinus and cranial chamber. They presented with exophthalmos pulsations, protruding eye, murmurs, and so on. And Dandy published the classical monography in 1944 about 108 patients with 138 aneurysms. Only 4 of them had been visualized prior to treatment, concerned with toxic effects of thromboembolic complications. So also Almeida had problems with arteriography. Olivier Corona and his scholar Norlin reported in 1953 about 63 patients subjected to direct surgical attack in the free interval quiescent period. Ligation of the aneurysm's neck was possible in 76% in 15 patients operated on. In the acute stage, that was from a few hours to 3 weeks after start. The mortality rate was 53 and the success, of course, 47. Then vertebrobasilar aneurysm, the first definitive intracranial treatment of a posterior circulation aneurysm, was carried out by Olivier Corona, famous neurosurgeon from Stockholm, in 1932. Then Charles Drake and Henry J.M. Barnett, they founded a department of clinical neurological science. This is the first type of institution where they joined the diagnostic, the neurology, and surgery in London, Ontario in 1969. Then clips were designed. Olivier Corona, Mayfield, Scoville, Silverstone, and surgery of the posterior circulation aneurysms was further taken up by great Yashargil, Sujita, and others. The operative microscope, Cerebrovascular Microsurgery School at the University of Vermont, Donegal, was very important. Yashargil visited Donegal and almost gave up. One morning, when he came to the office of Donegal and he said, "Goodbye, I go back to Europe. Microsurgery doesn't work." And at that moment, the nurse of Donegal entered the room. She said, "What's going on?" And then Donegal told her the decision of Yashargil that he will go home because this doesn't work. And then she said the most important sentence. She said, "Sir, don't you know that we all have a good and bad days? Why not to try once again?" And on that very day, Yashargil succeeded to put a micro stitch on a small vessel. And that was the initiation of his further development. And then he developed micro instruments, new aneurysm clips, controlled suction, bipolar coagulation. But parallel to this, also the neuroanesthesia was developing. But look at the devil. Then Serbirenko in USSR made the endovascular treatment of intracranial aneurysms. Nobody else did this in the world. So Gerard Debrun went to Moscow, visited Serbirenko, learned his technique, and came back to France. He was not able to develop it in France for whatever reason. I don't like to go in. Then he left for Canada, and then he spread the idea over Canada, US, and USA, balloons, coils, stents. And this great enthusiasm pushed surgery to the border of the field of treatment of intracranial aneurysms. I was one of those old dinosaurs because I was always in resistance to this. And that's why I was persona non grata in France. And you see the protagonist of endovascular, Jacques Moret. That's him. He's very good. Then Balavanis from Zurich, very good. Berenstein from New York, very good. I have no picture from Viruela, Fernando from Montevideo, very good, but not so good that they could kill neurosurgery. And then I met Daniel Rufenag, who was in the States, but originally from Switzerland. I said, come back, help us, and help us to join the forces that the surgery and endovascular treatment of aneurysms can be the only solution. And he did it. Important events in Europe. The first microneurosurgical workshop in Zurich was in 1968. The first international microneurosurgical meeting was in Vienna, 1970. Events in Ljubljana. We got the microscope at 68. Microsurgical repair of the nerves started 69. We got the first cerebral aneurysm, and I was operating this under the microscope. And it was fantastic. My professor, he performed the craniotomy, and then he did the exploration of the area. And when he came to the aneurysm, he said, now you take over. You know, it was just upside down as it is today. Then we got the second microscope size at 74. And we organized several microsurgical courses. And later on, we also started with the cavernous sinus. And this is Professor Jumber. He was working together with Clovis Vincent in France, Paris, who was the pupil of Babinski and Thierry Demartel. And he profited from both. And he became better than any of them. That's why the war started and he left this hospital. And this is our course at from the 20th to 22nd of April, 78, when Yasher Gil helped us. This is Yasher Gil and Diane, and this is Professor Rumer. And this was a very important turning point in our city. Now, convergent events and procedures like magnification, microsurgical techniques, microsutures, bipolar coagulation introduced by Mellis, stage suction, Yashergil, and above all, microneuroanatomy. But parallel, anesthesia was also developing, and the first ether anesthesia was performed in Etherdome in 1845, but there was another one which was already before, somewhere in Virginia. Offsprings from peripheral nerve surgery. Smith from Walter Reed Hospital, published in 1967, first publication of microsurgically treated injured peripheral nerves. Microvascular procedures and EC-IC anastomosis and other microvascular reconstructions could take place. Pioneers, we should never forget them. Dr. Kersey from LA, a very important neurosurgeon and successful, dealing with the microscope. Rand, also in the US, Donaghy in Vermont. He is important because he created the school which Yashergil visited and then continued in Europe, in Zurich. He organized the first workshop in '68, and he also at the same time presented his small booklet, Micro Neurosurgery. Everything is there what a resident needs to start. Now, how to have a Yashagil's control at aneurysm surgery when he is not present? Because we all need control, we all need guidance. We cannot go completely alone. I was fortunate to spend some time with Yashar Gil in his operating theater, and this was in 1990. I operated an aneurysm, and then Yashar Gil came to the OR, and he said, yes, compress, the brain is not yours. At that moment, I realized that I am doing something very wrong. I said, I will not do it anymore. Spatulas. Holding the brain, yes. Retracting and compressing the brain, no way. The aneurysm clipping, everybody can do it. The cost is very different, and we don't pay it. The patient does pay it. Maurice Halby, famous neuroanesthesiologist from US, he did experiments on monkeys. You can find this on internet, and he showed detrimental effect of spatulas compression on the brain. They are a cascade of events, physical into biological. Approach to the target. Respect the brain's anatomy. Do not destroy it. Get in, fix the aneurysm, get out without leaving traces of being there. Be like Houdini. Be a thief who does not leave the traces. Guidance. Just one example. Babinski helped Thierry Demartel in Paris what to cut and what not to cut. Clovis Vincent, who was their pupil, he was watching and learned from both. But Yashagil taught neurosurgeons microtechniques. First micro-neurosurgical meeting was in Vienna, and then he explained self-guidance, positioning of the patient. You have to do it. You, the operating surgeon, doesn't matter what kind of degrees you have. And then you have to take care about the correct protective dura opening, gentle arachnoidal dissection, and absolute pia and veins preservation. You may have a patient with a small aneurysm like this on the carotid, or the same patient, one in the communicating anterior. And this is how we have to approach. We cut the dura along the Sylvian fissure. We are on the right side. And then we try to use arachnoidea to fix it to each side when we are splitting the Sylvian fissure. But by no means we are allowed to destroy, cut, or coagulate the veins. If we preserve the veins, we have our own good guidance. But when you sacrifice the veins, when you have the bleedings because you damage the pia, you are not doing well. Yashagi told me that he tried to, he was teaching the arachnoidea to the dura. He told me that he tried to convince young people to study Sylvian fissure. This is the most important approach to the skull base, intradurally. And he was sad. He said, nobody doesn't like to work on this. And till now, we did not have a good study about the connections between the frontal and temporal lobe over the Sylvian fissure. But if you do the dissection very carefully, you will not damage the brain. You do not put the spatula, because when you put a spatula, you have a constant pressure, compression of the brain. And if this is too much, then you stop the arterial income first, the exit of the blood, and then the income. So, but if you put a bit of pressure with your suction tube and with your forceps, it is only temporary. And this is good. This does not create any biological changes in the tissue. So short-lasting compression and dissection, and then the brain has the time, has the possibility to recuperate. So dynamic retraction, not static retraction by spatula. And of course, you work with sharp instruments, and to preserve the veins. Maybe this is not the vital vein, but it is a control of yourself over your technique. If you succeed to preserve these veins, then you were not too rough, too tough to the brain tissue. And Yashagil wouldn't say, compress the brain, it's not yours. You see, and we have now the carotid, the middle cerebral artery. We have we can dissect further down, but again, look, with suction tube, I do all the space. I retract a bit, I release, retract, release. Now we are over the optic nerve, and we are approaching to the aneurysm. The same technique. And please keep in mind that you should not put your head away. You should not leave the aneurysm one fraction of a second alone. You have to watch at the aneurysm all the time, and you communicate with the nerves with words. Sometimes, when I have a bleeding, I'm speechless. But don't turn your head away. No, because in this moment, the aneurysm can rupture. And I had such a case. And of course, the patient died. He was completely normal before. This was my mistake. So The aneurysm should be always in your visual field. You should just stretch the hand to take the other instrument and to do the further dissection. Don't leave aneurysm 1 single second out of your visual field. And it doesn't matter if it is large or small. All of them do rupture or may rupture. And you know Murphy's law. If something is possible, it will happen. So then you put the clip, and it's not enough just to put the clip. No, you have to be sure that the clip is positioned correctly. You have to reposition it. You have to, sorry, I got it. I made a mistake. I will come back. So we have to check, and we have to reposition the clip, and then to visualize the parent and daughter arteries. It's the ACA1 from the other side, communicating, penetrating, and the whole situation should be clear. So you don't need angiography after such a surgery and after such a video, but we have to do it for the for other reasons. So this is the aneurysm is fixed, you see. And then now we go to the other aneurysm, which is on the carotid. Perforators. Pay attention to the perforators all the time. I think we can finish here. And you can see the veins are preserved. These are important veins. These small veins here, I don't think they were so important, but they are the guidance. They are witness of your excellence. Okay, further now. So you see the dura cutting is along the Silvian fissure. Why? Because if something happens, and if I am in a difficult situation, then I will put the spatula, and spatula will be protected by the dura edge, not to compress too much or too far. Now, we come to the large and giant intradural aneurysms. Like this. In this, we need space to come around and to put the clips. The space is needed anteriorly to it. We have posteriorly the space. And we can deal with such an aneurysm and preserve the carotid ophthalmic. We can deal with a large 5.5 in diameter aneurysm, and what you notice here, this artery has no ACA1. So you should by no condition to occlude the carotid or the middle cerebral. You have to preserve patent carotid and middle cerebral and remove the aneurysm. Here I will show you a mistake, my mistake. You see a large aneurysm and communicating posterior, yes? I resected it, I reconstructed by sutures this artery, but control did not show the communicating posterior. Why? Because I calculated the diameter of the artery from the outer aspect, not from the inner aspect. And the wall of such an aneurysm is width is larger than normal. So you have to calculate always inner volume. Then you can see an aneurysm at the communicating anterior with stage thrombus, calcified and different ages. The ESA didn't show something clear. So we performed another imaging where we realized that there is no left ACA1. And this is the complex irregularities, and here ACA1 left is missing. We had to resect the aneurysm. We have to reconstruct the communicating anterior and ACA origin on the left side. So we have now both ACA2 and no deficit. And you see here, there is no left ACA1. So these were intradural aneurysms. Now, carotid ophthalmic, they are also intradural, but you have to ask yourself why microsurgery of extradural structures became inevitable. Because to gain space, you have to go through the dura laterally, anteriorly. Exposure, sufficient space is needed, proximally and distally to the aneurysm. No need to expose the entire aneurysm dome. Extirpation of the aneurysm neck, a sac, is dangerous. Surgery, the lateral skull, at the lateral skull base dural border is not just one step more laterally. There are new territories. Don't think that if you operated many aneurysms intradurally, you can go easily extradural because this is just a bit laterally. No way. You have to know what is on the other side of the dura. At the International Neurosurgical Meeting in Munich, 1981, I presented the anatomy studies I did on the paracellar region. I was proclaimed to be insane, except by 2 delegates. But I was talking about the ACP and PCP bony protrusions into the dura, about the cavernous sinus anatomy, about the petrous bone, covered, of course, by the dura. And when you are working here, you have to work very diligently. You have not to be tough. You have to be very gentle. You have to take into consideration anatomical structures, paracellar ICA, cranial nerves, triangular areas, and so on. Anterior clinoid process, represents space limitation when we are dealing with carotid ophthalmic aneurysm. And here you see from the lab, on the left side, we have the optic nerve through the optic canal, mucous membrane, and then we have the dural ring around the carotid, and we have a proximal ring covering the third nerve. And when we remove the anterior clanoid process, we get a lot of space. You see? And then we follow the ophthalmic artery. And we have all this under in our vision field, visual field. But to do the excision, the extirpation of the anterior clanoid process, you can train yourself on an unboiled head. No drilling perpendicularly, just do the brushing. And if you do the brushing of the bone over the optic nerve, over the third nerve, you will never damage those structures, neither by physical, neither by thermal. You have to visualize the ICA, intrapetrous, extradural, paracellular, and intradural. Intrapetrous, in the sinus, anterior clanoid here, and intradural here. Look, intracavernous and intradural segment of the carotid are parallel. And you see here, we are from the right side now. And we named carotid in this segment through the skull base that it is looping, has anterior loop, has medial loop, has lateral loop, and posterior loop in the petrous bone. Again, we are after the removal of the anterior clanoid. Don't go too far in the depth. Don't enter the sphenoid sinus. Don't damage the third nerve. Don't damage the optic nerve. And if you do this in the lab, I always ask the participants at the workshop, if you will damage one of the nerves, you will pay $100 to me. Because if you say, oh, it is nothing, in the lab I can do it, I will not do it in the live surgery. This is bluffing. This is bluffing. It will happen in the surgery. Now we have such an aneurysm, carotid ophthalmic. And again, the same principle goes through the Sylvian fissure. But first, remove the sphenoid wing, remove the anterior clanoid process, visualize the intracanalicular segment of the optic nerve and the anterior loop of the carotid in this triangle. Then you come from the distal side of the carotid, of the aneurysm, and you see the brain here. It is over the aneurysm. You don't need to visualize the whole aneurysm. You just have to visualize the origin of the aneurysm. But can you imagine if you have only this space, only this, and if here is the bone? You are not safe. You don't know what will happen. But if you're working on both sides, look, extradurally and intradurally, you have the origin of the aneurysm, and now you have to visualize it better. Optic nerve is this. The anterior loop is there. Now what we have to do, we just cut the dura toward the dural ring around the carotid. Look, and then we will put a stitch here and we will lift it up. Look, we put a stitch, we lift it up, and we come to the orifice of the aneurysm. So we still need more space here. We go further down. Here we can visualize the ophthalmic artery. And if the optic strode is still not allowing us to come around the carotid, you can cut further. You can drill the optic strode, and then you come to the carotid. Look, we are at the carotid. And this is the origin of the aneurysm. Here, here. And now we have enough space. We don't need to explore the whole aneurysm, which is under the brain. We just catch the aneurysm at its basal portion. You see the optic nerve here behind? And you hold the aneurysm. And now you come with a clip, a bit curved clip, with the left hand, and you put the clip around the neck of the aneurysm. You are away from the optic nerve here. You are holding the artery, the aneurysm, and the carotid is here. Now you just cut the aneurysm. You don't need to explore it completely. No, you just cut it. Just cut it and empty it. Never pull it out. If you will do it, you will ruin the hypothalamus. And then the patient will not be doing well. You see, we have the central part of the aneurysm. We have the optic nerve down there, and that's it. And we were working on a very small area. And we preserved all the veins. We preserved the brain. We left the dome of the aneurysm underneath. But it is not dangerous. It's not bad for the patient. Because if the brain could cope with the aneurysm pulsating and full of blood, it does not hurt the brain the rest of the dome. This was before, and this is after surgery. Ophthalmic artery is preserved. This is the clip and the carotid. Carotid preoperatively, postoperatively, by clipping. Remember, it is helpful to cut the dura along the cerebral fissure, not do a flap. If you do a flap, you have no protection of the brain. If you cut it along the cerebral fissure, you have the protection. And for instance, in some cases, you don't need to explore the aneurysm at all. This is the optic nerve. This is the dural ring. This is the extradural carotid. This is the intradural carotid distal to the aneurysm. You just put the fenestrated, angulated clip, and that's it. Ophthalmic reserve. Now, extradural aneurysm. Why to operate cavernous-sinus ICA aneurysm? Are there absolute indications? Maybe. Bilateral, fusiform, traumatic. You have to provide safe dealing with the aneurysm. Resect the ICP extradurally. Distally, you dissect the ICA and the optic nerve free. Proximally, you get control of the blood flow in the ICA, in the cavernous sinus segment. So, you remove the anterior clinoid. You visualize the ICA anterior loop. The proximal ring is here. The optic nerve is here. And the lateral wall of the cavernous sinus is there. Posteriorly, you visualize the V3 Gacillion ganglion and you open the carotid canal in the petrous bone. And yet you can put the clip here. You know, I did not invent this. You know who did? Peacock, an ENT surgeon from California, when he was student, and later on when he was the residency at ENT specialty, he did this, and he published this in Nobel Symposia 1960. Nobody read it. I did. I stole it from it. Look, this is before and this is after. This patient was treated by in 2 other centers, and they could not exclude the aneurysm. But by this technique, when you remove the anterior clinoid, you visualize the anterior loop, you visualize the posterior loop of the carotid, you have a control over the flow into the ICA, and then you can put the clip. Here I made again a mistake. I was calculating the outer diameter, not the inner, but luckily enough, there is flow. You may have such an aneurysm. Carotid is this, ophthalmic, and huge aneurysm. You have to resect it. You have to reconstruct the carotid and to preserve the ophthalmic. When you have a double bilateral aneurysm on the cavernous sinus, then we go on the larger one and we just follow the smaller one. It's not necessary to hurry. If it will enlarge, then you can operate or you can make a stent or whatever. We refined this technique so much that we were operating only extradurally. We didn't even enter the dura. And this is a medical dog treated somewhere else and had subordinate hemorrhage and was in bad condition when he came, but finally they treated him for infection, for other things, and finally we were able to operate on him and resect the aneurysm and reconstruct the carotid. Here is another my mistake. I was a bit arrogant and I said, I can operate this only extradurally. I will not open the dura. But the first mistake was not only mine, was also the radiologist. They did not realize that this kind of protrusion might be another separate aneurysm. I removed by extradural approach this aneurysm, resutured the carotid, which you see here, resutured carotid, but this is another aneurysm, which is intradural. And we realized this after surgery. So you can do this with endovascular or you can operate whatever. You may have a partially thrombosed, partially active aneurysm, and then you have to reconstruct. And this is even better seen here. This is only part of the aneurysm, which is active, and part is thrombosed. But be aware that with partially thrombosed aneurysms, you might have a diseased artery before and after, proximal and distal to the aneurysm. So this aneurysm, we resected, we reconstructed, and then it became occluded. So we went in the second time, and then we put the short high flow graft, and now it is working. I hope you agree with me that this is not for endovascular surgery. Nobody can come with the catheter and find the distal end of the artery. You have to go into the field. You have to find the distal stump and then to connect it to the proximal, and then it works. You may have also some other kind of injuries like this. The nail went through the nose, through the cavernous sinus, and through the artery. So what to do? This is not for endovascular, my friends. It is our territory. And this is before surgery, and this is after surgery. The nail was taken out, and the carotid was sutured. And this is how it was during surgery. This is on the left side. Optic nerve, anterior loop of the carotid, the nail coming through the cavernous sinus and through the lateral wall. And we also visualized the posterior loop of the carotid in the petrous bone, so that we were able to put the clip here and to put the clip anteriorly, and the artery was empty, was free, was not dangerous. So we went, but you have to know this anatomy, how to go between the nerves. Now we come to the most difficult, to the most dangerous part of vascular intracranial surgery. And for me, these are basilar aneurysms. Indications for surgery of basilar tip aneurysms: large and giant, complex, and failed multiple coiling. Because for endovascular people, they say, oh, basilar tip aneurysms are the easiest one. You just get in and that's it at the end of the basilar artery. Yes, but they are also perforators, and you should preserve the perforators, and that's the whole point. And this is such a case. I operated this patient in another country, and he came to me and he said, you know, my pocket is empty. I have no money anymore. Can you fix this aneurysm? And we did. This was pre, this was post. This was pre. You see, the coils moved posteriorly, and the aneurysm grew anteriorly. And this is after our surgery. You see, Spetzler has a lot of this material. He operated many aneurysms coiled before. But you see, the perforators here, you have to visualize the perforator. You have to be aware that perforators do not tolerate any clipping. If you clip perforators, forget, the patient will die. Prior to operate on basilar tip aneurysm, one should be familiar with aneurysm surgery along the corridor. MCA, distal ICA, in carotid of Carmen. Unless you qualify on all these aneurysms, it's better not to operate on basilar tip. Widen the corridor, open the Sidian fissure, as it was shown before. Shift the cavernous sinus wall laterally. And this is an example. Anterior clinoid process was removed. You see carotid. You see the perforators here. if you enter this space, then you push the carotid laterally, you stretch the perforators, and this is no good. And on the other side is optic nerve, of course. But you have an empty place here. After removal of PCP, you will enlarge this space. And you can easily move the carotid medially. The perforators will be relaxed, not stretched. You see, you remove all these and you visualize even the pituitary body. And you see the third nerve is under your control, is in your visual field. So you will not damage anything. I have to admit that later on I read in a publication with which published Samson Duke from Dallas, he said, we were aware of drilling of the posterior clinoid process, but we considered it too dangerous. So, but with the gentle drilling, you can do it. And then you come along the sphenoid wing through the anterior clinoid process, and then you continue through the posterior clinoid process, and you come down. You come down to the posterior fossa. Remove the anterior clinoid extradurally. Remove the posterior clinoid. Also from intradural to extradural space. And then you're at the basilar tip. But to do this, you better first go to the lab. You take a glass, 10 centimeters deep, and you try to suture a small vessel at the bottom of it. You will not believe how different it is when you are working on the surface or when you are working in the depth. Three-dimensional actions in the depth are something very special. But you can do it. You just have to try it. And then you can do the complex aneurysms. And look, perforators are preserved because for this kind of aneurysms, I learned something from Peter Bentivoglio from Australia. When he was at the Queen Square Hospital in London, he was doing the research on occluding the basilar artery. He did this on the apes. And he found that if you put the clip for 3 minutes and then off, you wait for 5 minutes, again 3 minutes, nothing will happen. So you have time. You put the clip distal from the superior cerebellar artery, and then you dissect the aneurysm and the artery, and then you can safely put, you have an intermittent preservation, intermittent occlusion of the basilar artery. You can do also deal with this large aneurysm. History. I said Hugh Sampson did publish this. I have a similar story with Yashar Gil. He wrote a foreword to my book at 1989, very positive. But at 1992, he had an aneurysm, and he said, no, this cannot be operated. I said, Professor, why not? He said, yeah, you are a lunatic, you can do it, but the patient will die. Then I said, Professor, let's have it do it together. I will do the approach. I will remove the anterior clinoid, sphenoid wing, anterior clinoid, and posterior clinoid, and then you will do the surgery. And so we did. And he did a wonderful dissection because he had enough space. After fixing the aneurysm, he turned back to me and he said, you know, I did not believe you before. Now I believe you. So I was very happy to convince the great master. Surgery in the lab prior to central skull-based live surgery is a must. If you don't do this, you will not be happy. Evolution of the approach to the central skull base, we were talking about this before. Until 89, I was doing this approach from the lateral side, and then I cut the dura like this, you know, to come to the cavernous sinus, which was actually not correct. It was like to go through the sleeve here and then come here down. So why not just to pull the dura a little bit back, and then you have an exploration of the paratellar space. And that's why don't read my book 1989. Read that one from 2003. This is readable. And I can say this not because I was the only author. Larry Rogers from Charlotte worked with me 1 year before he said, now it is readable. Now also the Americans will read it. So you just pull the dura back, and you protect the brain. Then you see everything from the front to the posterior side. You see, and if you are operating on anything, tumor or aneurysm here, you just open here, the anterior side. If you operate on the whole cavernous sinus, you open the whole. And if you operate something at the apex of the pyramid, you open posteriorly. Now, in conclusion, respect different locations of the aneurysm: extradural carotid, intradural carotid, and vertebrovascular. They are very different issues. Mind the size and content of the aneurysm, quality of its neck, and condition of the artery. Too many times we forget on the conditions of the artery wall, parent and daughter. Ruptured versus unruptured aneurysms, very different issue. Atraumatic approach and sufficient exposure of the parent and daughter arteries in the neck of the aneurysm is very important. When clipping is not possible, resection of the aneurysm, reconstruction of the artery wall with suturing, wrapping, and reinforcing with cuff clips is needed. Conclusion further: no clipping, no resection, no reconstruction possible. Bypassing is needed. Short, high flow, and or EC-IC bypass needed. Large neurovascular centers are needed. First-class diagnostic procedures available. Good endovascular treatment possible. Experienced neurosurgical and neuroanesthesiology teams present. Individual consent for the kind of treatment. At the end, I would like to say, nothing is complete, nothing is definite, everything is changing, and neurosurgery is not an exception. What is? What in the future? Are we really out of neurovascular surgery? No, no, no. Aneurysm clipping will survive for certain locations, certain qualities, certain size, and so on. It will be necessary for arteries reconstruction, bypass surgery. Also AVMs, we are not completely out, no. And more vascular diseases are present. Revascularization procedures are needed we have to continue. And not completely at the end, but I would like to stress that the last decades, we were concerned about the arteries. But the next decades, we have to be concerned about the veins too. The veins are important. And they were never dealt with such an attention as arteries. And this is existing literature. You see there are some translations into the Chinese from 2003 and the last one. And this was the first about after the meeting we organized in Ljubljana at 87. And then we published this at 1989. It was at the time of international meeting in New Delhi. And then more questions. They were killing me. They were attacking me all the time at all congresses that I did not tell this and that and so on. So, and since this book was sold out in 1 year, they said we will republish it. I said no, because there are many things they have to be corrected, and that's why we continued with workshops around the world. This was in Virginia, UVA, 1891. Then in St. Louis, 97. And then finally, I was able to put together the material, and Larry Rogers helped me to make it more readable. And then the Chinese realized that it's something good in this book, and they translated it. What I discovered by accident. You know? And when the book of 2003 came out, Dwight Parkinson wrote to me that your book arrived today, an encyclopedic masterpiece. How delightful to see the term cavernous sinus omitted. His work is yours, should keep the balance to the nomenclature committee. But remember, the anatomists are die-hard toward the changing any name. And it will not happen so easy. And also, he liked the Charlie Drake picture when he is smoking in front of the non-smoking sign, because he was the only person at his time who was allowed to go over the cutting edge. All the others, we were followers. And he also, Parkinson also liked the suggestion that surgeons practice burring on an eggshell. And I think it's very, very useful. You know what happened? At 2007, I was granted by a credit that I can also organize a workshop from in the name of the World Federation Neurosurgical Society Education Committee. That's the whole story. Thank you very much.
Thank you very much, Professor. We have a few questions for you. We are short of time, but we will make you as many questions as possible. First of all, what are the advantages of proximal intracranial carotid exposure for proximal control compared to neck exposure?
It depends on how familiar you are with the. You can do the neck exposure. This is, of course, the easiest one. Then you can do the exposure of the carotid in the petrous bone. You just drill the petrous bone posterior to the gasserion ganglion and from 8 to 10 millimeters medially from the foramen spinosum. Then you will not hit the carotid, you will not jump into the posterior fossa. You just drill that and you will open the carotid there. But according to the picture, to the DSA, you will realize if the carotid aneurysm, carotid-ophthalmic aneurysm, for instance, is pushing and destroying, degrading somehow anterior glanoid, then you can do this. But otherwise, you can just remove the anterior glanoid process, and you will be in the anteromedial triangle between the optic nerve and the third nerve, and then you have the anterior loop of the carotid.
Okay.
You have three possibilities. It depends how skilled you are and how familiar. But of course, in the lab you will see these possibilities.
Dr. Dolenc, my name's Steve Monteith. You probably don't remember, but back in 2007, 2008, when you used to come to University of Virginia, I was a resident there, and it was a privilege to actually watch you operate on some of Dr. Steiner's patients. Yes. And we learned a great deal from that. My question, firstly, thank you for your talk. And my question is, middle cerebral artery bifurcation aneurysms, there's a move in Europe and also in the United States to move away from clipping. We're still seeing some recurrences with endovascular treatment. People are putting flow diverting stents into middle cerebral artery bifurcation aneurysms. What is your view on the role of microsurgery with all these endovascular techniques for middle cerebral artery bifurcation aneurysms? Thanks.
That's the real question, which address actually the joint work, the work in bigger centers where you have the ability of endovascular and microsurgical approach. It depends how you can localize the perforators from this point, and the main question is anterior choroidal artery. You see, you should not damage it, and if you cannot dissect it from the aneurysm, then you are in the risky area, because in many cases nothing happened. But when it happened, I had only one case among 3,000 aneurysms I operated where the anterior choroidal artery was responsible. Actually, I did a mistake. I cut it, I clipped it, and the patient was hemiplegic, like cut off. So I'm afraid of anterior choroidal as well. I'm afraid of ophthalmic artery. Ophthalmic artery can also be damaged, and in most of cases nothing happened. But when it does happen, it is definite. So I would say if we are working together, endovascular, and with these new devices they have with the stents, you know, if they can provide a good work, okay, I have nothing against. But we can also do this way, that we do the dissection, and we do sometimes, you know, we explore proximal, we explore distal, that is the middle cerebral and anterior cerebral artery, first segment, and carotid, and we see if we can deal with the perforators, okay. If not, we say, okay, let's go with the stent. But this is very important because sometimes from the very bifurcation, some lenticular striates are come. And there was an Italian author, Dr. Dappian. He published quite a, I don't know exactly how many cases of this aneurysm at this location. That is the distal intradural carotid, the beginning of the anterior ACA1, and the beginning of the middle cerebral artery. So I don't know if I was clear enough, but we can decide, shall we do surgery or endovascular according to the DSA, how we can anticipate and decide. If we cannot, we did some cases with combined. We operated, we said, oh, no, it is too difficult, it is too dangerous. We don't know if he will be able to preserve. And then the endovascular put this kind of stuff.
Thank you.
This is the very delicate position.
Okay. And Dr. McDougall has a question.
Yes.
Professor, I want to first of all just thank you for the gift of being with us this morning. It was just a delight to hear your talk. And I want to also thank you for a kindness you did to me many years ago. My name is Cam McDougall, and I worked for a long time with Dr. Spetzler. And I was offered up as a sacrificial lamb one time in Brazil. Dr. Evandro Dolenc had invited us both to share the podium, and it was usually a fairly hostile environment for endovascular people. And leaving the meeting, I got onto the airplane and sat behind you, and you turned to me and you said, "Keep it up, you're doing good work." And that little word from you those years ago meant a great deal, because I knew, of course, what a giant you are, and that you had been through many hardships advancing the field. And that brings me to my question, which is, you talked a lot about actually the kind of pivotal moment when Yazergil turned to you and said, now he believes you. But many years before, you started down that path, and I'm wondering, particularly for the younger people, what gave you the courage to know that you were going to be able to go further than other people did, long before that time with Yazergil? Somewhere, something in you made you think that you could go further than other people had.
Actually, once I was, it was 78, I think, I was invited by, it's difficult to say invited, I was ordered by an elderly colleague to help him to operate on an aneurysm, to assist him. I said, yes, but Professor, this will be difficult. No, don't worry, we will manage it. And this was a young lady. And of course, this was a carotid ophthalmic, and we did not actually, he did not manage it. We ended up with plugging the carotid and the aneurysm. The patient died. So I said, my gosh, if this is neurosurgery, I will give up. This is not what I can live with, to operate, and then the patient died, and you go further. So, and then I said, but look, maybe it's something we can do. So I went to to a colleague who was the dentistry doctor, and he borrowed me a drill. And then but you know, this was the cutting drill. My gosh. And then with this cutting drill, which was crazy, I was able to remove the anterior clanoid. And then I said, but that's it. We have to gain the space. We have to gain the more space on the expense of the bone, which is not functional. Anterior clanoid process does not have any function, you know. And so then step by step, I was advancing. And then I was in Sweden, and somehow, I don't know who told me, did you read the Dr. Peacock's exploration of the carotid in the petrous bone? My gosh, I had both eyes open. I said, that's it. And so I started. But to come back, it was funny. When I presented my work for the book of 1989 to Yashargi, he said to me, why didn't I do it? He was angry with himself. Why didn't he do it? I said, Professor, you could not, because you were overwhelmed with too many cases. You did not have time. And he learned later on how to resect the anterior clanoid and how to deal with the carotid ophthalmic at his age. So it was just a coincidence, you know. And I was not lucky. I was not happy in Munich when everybody was against. Only PV House from LA, he said, no, this can be something. We have to keep eye on it. And that's, you know, a little help from this and a little help from that side. And some facts already published very close helped me to go ahead.
That's a great story.
Because nobody can invent everything by himself. We all are staying on the shoulders of our predecessor, you know.
Yes, but I'm sure it was a lonely place for you for a time there.
Thank you.
Thank you, Professor, for your talk. We're deeply grateful.
I'm looking forward. If I will be on my feet, I would like to come to Seattle and to share the things with you there in the lab.
One question for you that we're very curious about is dissecting over veins. We find this to be the most difficult part of arachnoid dissection.
That's
and
correct.
what strategies do you have for preserving and safely dissecting over the top of veins?
Do sharp dissection. Do sharp dissection. And don't be in a rush. No. Remember the old Chinese proverb. Those who will go slowly enough will come the first to the end of the road. Don't rush. Don't rush. You know, I can tell you that if I go to the street in front of the hospital, I take a random person who has no medical knowledge. I bring him to the operating theater. In 1 year, I will teach him, and he will learn how to put a clip on the aneurysm. But I will never be able to teach him, and he will never learn how to come to the aneurysm or to the target. Come there and come back without traces that you were there is the most important. And sharp dissection. Do it on fresh cadaver specimens. Do it, and you will see how many strands are between the frontal and temporal lobe. Beside these variations of the operculum, one over the other or each to other and so on. But when you learn, when you really master the only arachnoidal way, you will preserve the veins. But you should also try not to damage the pia. When you damage the pia, you are not gentle enough.
Thank you very much, Professor. Thanks.
And there is no short way. There are hours and days and months in the lab. And if I'm allowed, I can give you another proverb from China. They say, I am not afraid of somebody who tried 10,000 of different kind of stroke, but I'm afraid of this one who tried 10,000 times one single stroke. This one is dangerous. This one has mastered. Not who had tried everything. No. Sharp scissors, gentle traction, cutting, advancing irrigation, and so on. That's what is really helpful.
Professor, another question that is very important for us, for the young neurosurgeon, is how, if you have some ways to prevent the drill from skipping or jumping and inadvertent injury of structures around the drilling zone.
Yeah. Take the egg shape. Brushing, not drilling. Brushing, not drilling. If you brush everybody is so enthusiastic about a high-speed drill. Damn, I am also. But when you are drilling the bone over the optic nerve or over the aneurysm inside, you have to do just a few revolutions of the drill, then stop, and then irrigate and check, and then continue again. It doesn't matter if you spend 1 or 2 hours, but you will not damage the optic nerve. You will not jump into the oculomotor. You will not jump into the carotid, and you will not hit the optic nerve with the heat, because if you drill, the heat is produced, and the heat can damage the optic nerve. That's but go slowly, make few revolutions, stop, and that's why I was somehow against these high-speed drills. They are nice, they are good, but when you are dealing with the delicate structures, don't them pull you into the delicate structures, and then you say, oh, now it's too far, but there's no way back. So if you like another suggestion, you have to conditionize yourself. You have to talk with yourself. Okay, now I'm over the optic nerve. I will do few revolutions, I will irrigate, and then I will check, and then I will continue the same way. So you have to conditionize yourself, because when you see that you are too far, you cannot stop. You cannot stop. Your hand is still holding, and you are still drilling, and you see you are drilling, but you cannot stop. So you have to prepare yourself before, and that's the only way how I can deal with it.
Okay, Professor, we have a few more questions. You mentioned that you reconstruct arteries. Sometimes, for example, the ICA after aneurysm surgery. Is there any advantage of suturing the artery wall over clip reconstruction of the wall?
It depends on the wall of the artery. It depends on the area which is destroyed or necrotic, or whatever. Sometimes when nothing is possible, then I put a cuff clip, a small cuff clip, and I coat it with the Surgicel or muslin, and I put it around. You see, but mainly it is possible if you have a small leak or small tear, you can put 1 or 2 stitches.
One other question is related to something that you said, that also Dr. Monteith told me in a surgery, that what happens outside the vessel is not the same what is really happening inside the vessel. Sometimes when you put clips or something, you're really occluding the vessel wall. How can you identify this mismatch? How can you identify?
You have to, first of all, you have to be aware of the width of the aneurysm wall at its base. Because large and giant, they always have a very thick wall. And because we have in mind how big is the artery, but does not matter if you leave a little bit more. If you create not a fashion-like artery, but it is important that you create a fashion-like volume of the artery. So don't perform the stricture from outside. Just put more wall, and then don't worry if the outer diameter is larger.
Actually, we have many more, but I will try to filter. What do you think what are the current indications for cavernous sinus surgery nowadays?
Very, very difficult question, because you have this struggle, this war between the endovascular, radiation, and other specialties and surgery is still lasting, but I've been always fighting for the combined approach, that we have to realize before any act what is the best. This is important for the patient first, but also for the doctors. If we, for instance, we are 3 together, let's say a neuroradiologist, a endovascular expert, and one of us, neurosurgeons. And we discussed before what kind of modality we will imply. Then, if something goes wrong, we will not be against each other after surgery, you see, after treatment, or endovascular, or microsurgical, or whatever. So, this is important from the political and professional side. But I still think that surgery cannot be ruled out. No.
Okay, Professor, it's been a real pleasure for us to have you. Thank you very much for accepting our request and answering the emails and everything. It's an honor for us, and you're an inspiring figure for all of us. So thank you very much, and I hope we can have you some other time.
Thank you to you. It was an honor for me. I'm so happy when I have a contact with younger people, because this kind of surgery is for younger people.
Okay.
You know, they are still able to change their mind, to try different procedures, and the future is on you.
Thank you. That's really inspiring for us.
Thank you.
Thanks.
Thank you very much.
Thank you so much.
Thank you so much.
Thank
Bye.
you very much. Thank you.
Bye, Professor. Bye.
Bye-bye. Bye.
Bye-bye.